To be here. This is my first time in Shalimar Medical College. Hopefully not the last. Hope to be back again. So a little bit brief introduction about myself. I belong to Peshawar. I'm a graduate of Khyber Medical College, and after my house job, I took the PLAB route, and I went to UK, and I completed all my surgical training, FRCS, and then fellowship in breast surgery from the UK. And since 2017, I'm now back and based in Peshawar. So the topic given to me is the recent research and trials. Is the latest research and trials in the field of breast surgery. Now, who's into trials and statistics and odds ratios and area under the curve? So I can see the whole room full of excitement. It's not that complicated. So the essence of my talk today is AI in predicting breast cancer and impact on the traditional screening. So it's more about diagnosing, risk assessment, and predicting who actually will get breast cancer in the future. So who is more likely to get the breast cancer in future? That's $1 million question. If we could answer that, then that would make the patient's life easier and the clinician's life easier as well. And we've been trying to answer this question in different ways. And starting from risk factors. So we know there are risk factors which increase the risk of breast cancer, mainly hormone related. So the uninterrupted and prolonged exposure to hormones in the form of early menarche, late menopause, HRT, OCPs, and so on and so forth. Family history, genetics, and then using these, we've got risk assessment models. And the risk assessment models then categorize different population into low risk category, intermediate, and high risk category of developing breast cancer. And based on these different categories, they're important because the recommendation to each category is different. So for the low risk one, the screening guidelines are different. For an intermediate one, they are different. For high risk, they are different, including genetic testing and probably prophylactic endocrine treatment as well. So it's important to know what the risk of developing breast cancer is. So these are the ways in which we've been trying to answer that question. A little bit about breast cancer screening, because the papers that I'm going to talk about, the two trials I'm going to talk about, is potentially going to challenge the traditional way of breast cancer screening, and it's going to change the whole paradigm. So we know early diagnosis of breast cancer can save lives. So stage 1 outcome is better than stage 2 and stage 3 and so on. And that's why we have breast cancer screening, which started around about 1980s in different parts of the world. But there are variations in screening in different parts of the world. It's not the same everywhere. We're not agreeing on a few things in breast cancer screening. Number one is from which age to start and when to stop. So in the UK, the breast screening used to be from age 50 to age 70, and you would get a mammogram every 3 years. And now they're bringing it forward. So you start from 47 and they're going up to 73. And then there are other countries which start from 40. And some do it 3 yearly, some do it 2 yearly, some do it annually. So there's a lot of variation of how to do breast cancer screening. There's no agreement on that, but there is agreement on this, that early diagnosis saves lives. Now, if you come to our setup, we have other set of problems. So for breast screening to be effective, it needs to be on a whole large scale, on a population-based scale. Only then you can pick up enough cancer to make a difference. But then we don't have the infrastructure, and the financial impact is huge, along with public awareness and acceptance. So we have much bigger challenge for breast cancer screening. And this is the question. So can AI help us to make a tailored approach for breast cancer screening? So in the same country, in the same community, probably the same town, same city, can we advise different individuals about the start of their screening, about their frequency of screening, and all that. So can we make a tailored approach? And that would suit to our infrastructure and our financial situation as well. So this article was published uh, 2 years ago, 22, and this is on the evaluation of an AI model to assess future breast cancer risk. This is a retrospective study, and what they did was they took patients from the NHS breast screening program, which were screened in this period, February 2010 to September 2019, and they took their mammogram. So patients who were diagnosed both with invasive disease or DCIS, both of them, but they needed to have at least one normal screening mammogram. So a screening mammogram is in the UK at age 50, they get automatic invitation via a letter to come and have screening mammogram. Patients asymptomatic, they have a mammogram, and then it keeps happening at 3-yearly interval. So only those patients were eligible who had at least one normal screening mammogram with no cancer detection. They were included in this. So the difference between screen detected cancer and interval cancer, screen detected is the patient comes for the mammogram and has no symptoms, and the mammogram picks up a cancer. Interval cancer refers to patient previously had a normal mammogram, but before the next screening mammogram, patient develops a symptomatic cancer. So that's the interval cancer. Now, the AI tool which was used is called Mirai, and as Dr. Arfa hinted to it, it's a deep learning program. This was developed at Massachusetts Institute of Technology in about 2020, and this has 4 underlying modules. Each module, when a mammogram is fed into this AI tool, each module looks at it from a different angle, assesses it, and then it combines its outcome and gives you the outcome. And then it estimated risk for the next 5 years based on a normal mammogram. So it's not a mammogram with any suspicious features or findings. It's not a mammogram with diagnosed cancer. It's a normal mammogram, and it looks at it and then tells you what's the risk of developing breast cancer over the next 5 years. And only the last normal screening mammogram was used. So a little bit about, because this will come frequently, this is area under the curve. This is used for different tests. So the central line here signifies 0.5, and so the closer it gets to 1, the more accurate the test is. I'm going to skip this. They started off with nearly 18,000 patients, and then through different exclusion criteria, ended up with 2,044 screen detected cancers and nearly 700 interval cancers. Right. So need a little bit attention to this. How can we move this top bar? Because this is hiding the important bit. Yeah, thank you. Thank you. So if you look at it, these are the results. So that's the area under the curve, and as I said, the closer it gets to 1, 5 is by chance. So if the result is 5, that means the outcome is purely by chance. The closer it gets to 1, the more significant it becomes. And then odds ratio. So to interpret odds ratio, if it's more than 1, then the likelihood of an event occurring increases. If it's less than 1, then the likelihood of an event decreases. So that's just to give you an update. I'm sure you know about this. So overall, the patients who had normal mammogram but then developed breast cancer, interval cancer, or was picked up in the next 3 yearly to have a breast cancer, when they submitted those normal screening mammogram, remember they submitted the normal screening mammogram to this AI program, the odds ratio of that patient developing breast cancer overall was 1.72, which is significant, and the interval cancer was higher than the screen detected one. So the screen detected one would be at a 3 yearly interval, the interval one would be before that. So the closer you are to, or the closer a patient is to developing a symptomatic breast cancer, the higher the score. And this score is higher as well. I would particularly like to point out to, to a few things, a couple of things here. The comparison between interval cancer and the screen detected cancer. And I would revise again. So the screen detected is the cancer which has been picked up 3 years from the previous normal screening mammogram. Interval is before that. And if you can see, the accuracy of interval cancer is much higher with odds ratio of 2.33. The screen detected one is 1.43, and the area under the curve is also higher of 0.72, and the screen detected 0.63. Nonetheless, the AI showed a moderate risk and moderately accurately of who is going to develop breast cancer in the next 5 years. In this table, it shows that if the patient was going to be diagnosed with, so these are then, the staging is at the time when they were actually diagnosed. So the greater the stage, the higher the stage, the higher the odds ratio and the area under the curve. So for a stage 1 and or less than 2, you're looking at an odds ratio of 1.6, but for a more than stage 2 cancer, the odds ratio given on a normal screening mammogram by the AI was 1.94. And if you look at the area under the curve, it was 0.72 compared to 0.66. And the same with the nodal status. Those who were going to be diagnosed with positive nodes, their odds ratio is 1.92, and with a negative node, 1.75. Tumor size, if you look at it, so less than 1 centimeter, 2 centimeter, and as you go down, the tumor size increases, the odds ratio increases as well. Grade has no significance on that. So the closer someone is to developing a breast cancer but has a normal screening mammogram, this is very important. So under normal circumstances, someone would have a screening mammogram and then would go away and come back 3 years later for another screening mammogram. But if they have higher odds ratio, you can tell that person to come for a screening mammogram a year later and not 3 years later. And if somebody has a low ratio, you can even call them for a screening mammogram after 5 years. So you can tailor, this is still at early stage, but you can tailor the follow-up. There's an established risk factor for breast cancer, and that's breast density. So the higher, the denser the breast, the more the risk of developing breast cancer. And density is simply the ratio of the glandular tissue to the fatty tissue in the breast. So the more the glandular tissue, the denser the breast. So this is a software. Volpara is a software which measures and evaluates the density of the breast, and we know this is established. So then they compared the AI algorithm outcome with the Volpara and see how it performs. So breast density alone for those patients who developed breast cancer in the next screening round was 1.26, and for this Mirai was 1.69. So this has outperformed all screening, all risk detection models that we have till now. So the key results for this one is, this is a strong predictor of breast cancer risk. The interval and screen detected cancer are picked up similarly, but the higher for advanced breast cancer, you have a higher score. But that's not the end of the story. There's a problem with the Mirai, and that is, this is how, quote unquote, they describe the Mirai system. And it says it's a black box, a very large and complex neural network, similar in construction to ChatGPT, and no one knew how it made its decisions. So we didn't know, the researchers knew how they made their decision. It was tricky. So then we're now trying to decode this Mirai system. And the first go at that is ASIM Mirai, and ASIM stands for asymmetry. So one of the modules of the Mirai, it has 4 modules. So one of the modules of the Mirai looks at the asymmetry between the right and the left side. And this study, ASIM Mirai, this only picked up the asymmetry part, the asymmetry module of the Mirai, and subjected it again to the similar process. So what they did was they took mammograms from 2013 to 2020, and they used the embed set. The difference between this mammogram set and the NHS breast screening mammogram set is this is better because this is racially equally distributed. In NHS screening program, you have more of the local Western people than you have people of color. So when they compared it, the 1-year risk, according to area under the curve for the ASIM MIRI is 0.79, and for the MIRI is 0.84. It's not doing as good as MIRI because that's using 4 modules. This is only 1 module which is based on asymmetry between the right and the left side, but it's almost comparable. And the 5-year risk is 0.66 and 0.71. So the conclusion is that the radiologist can benefit from this as well, is that if there is dissimilarity between the right and left side, that is potentially an increased risk for developing breast cancer. So what happens after a normal screening mammogram? You have a normal mammogram, and then based on whatever protocol that country, that area, that population is following, you get called for another screening mammogram in 2 years or 3 years' time. But if you're using the AI tool, that can then risk stratify you based on your normal screening mammogram, and then can invite you for your next screening mammogram according to your risk, which can be in a year time, 2 year time, or even 5 years time. So it has better risk categorization following a screening mammogram. It can give you a tailored approach towards the frequency of mammogram, reducing the number of unnecessary mammogram, better compliance, and it's more affordable, especially for our part of the world, which we can't afford unnecessary investigations. Thank you.